Hi everybody, welcome to this evening and welcome to our webinar, Healthy Aging. I'd like to do the acknowledgement of country. The Sydney North Health Network wishes to acknowledge Australia's Aboriginal peoples, the traditional custodians of the land on which we meet and work. We pay our respects and recognise their continued connection to land, water and community and honour their ancestors, elders past, present and emerging. My name is Deborah. I'm the Primary Care Response Lead for the Sydney North Health Network, and I'd like to introduce this evening's speakers. So we have Professor Sue Curl. She's a geriatrician. She's with the Faculty of Medicine, University of Sydney, and Director Staff Specialist and Geriatrician at Hornsby Hospital. Chris is a GP in South Australia and a Director of GP training at the Queen Elizabeth Hospital for 12 years. He is the Director of BMP Healthcare Consulting. His areas of expertise include systems for chronic disease management, doctors' health, care of older people, the primary healthcare, community hospital interfaces, quality improvement, and change leadership. Jane, his wife, has worked as a general practice nurse in Adelaide for the past 10 years. Jane set up a healthy aging clinic at her practice with the aim to deliver more planned and structured care and to give enhanced access to those patients facing barriers to care. And Dr. Yog Chopra, he is a geriatrician, staff specialist at Hornsby Hospital. I'm going to hand over this evening to Dr. Chris Boland. But before I do, I wanted a quick just update of Health Pathways, which is one of the programs that we have within Sydney North Health Network. As of June, we've launched 427 pathways, and we've actually got 38 pathways in progress, and Chris will talk about that later in the evening. We've also got our new service, Health Navigators, that is being promoted around the area. It's staffed by professional healthcare nurses, and it's open from Monday to Friday. And it can help you navigate your older patients around the system within Northern Sydney, especially just in this region. Okay, so can I hand over to Chris?
Okay, so on your screen, hello everyone, Chris and Jane here in Adelaide. All right, so really what I want to look at, sorry about that little poor tech area, just thinking about how we're all going, all of us in primary healthcare, that it's not easy for us all. So, okay, so 50% of you are having more good days than bad, and clearly a few of us are having less good days. So I want to look at the next one, which takes us to thinking about your daily workloads, because this is going to be really important when we think about how we care for older people in our practices, whatever primary healthcare practice we're in. How are you all feeling about your workloads? Okay, so, all right, so the majority are in the middle, a few times a month. I know that as a GP, it's been pretty busy the last 6 to 18 months. So let's look at the next one. And this is about your training that you've all had in assessing and managing older people with long-term care needs. So I want you to think about which option best fits your situation. And it's interesting. So looking at the majority of people tonight, it reflects a lot of the sessions that Sue, Jane and myself have done around Australia where, the big issues are that we've got lots of older people in our communities. As health professionals, it's not necessarily part of our formal training. Thank you for doing that. All right, the next one, I want you to rate your confidence to recognise frailty and its complications in your older patients. Okay, so Sue, we've got lots of people that are in the good and excellent areas, so we better have our masterclass hats on here tonight. Okay, very good. All right, let's have a look at the next one. I want you to think about which evidence-based screening tool you currently use to recognise older people with or at risk of frailty. Okay. Right, so a variety being used. So it'd be interesting to look at the 13% that use other. All right, we'll keep moving. It's an interest of time tonight. I want you to think about your current barriers to incorporating frailty assessment into everyday encounters in your practice. Okay, so time is a leader here. So we'll be talking a little bit about, in your breakout rooms a bit later, what are potential solutions to that. Oh, lovely. So a good selection of answers there. So I can see that a lot of you are doing it already. So great work. Let's look at the next question. All right, which of the following statements is false? So one of these is a false statement. Good. All right. Well, I think the majority are on track with that one. So the protein, we need to really boost the protein after age 65 is really the answer here. Okay. So which of the following is false in this group? Okay, we'll move on. And the answer on that one is mobility is actually linked to an older person's dependence. All the others are true. Okay, next one looks at the risk factors of undernutrition. Which of the following are true? And this is the multi-choice if you want to. You can have a number of answers sent in. Okay, well, yes, one of the things that this slide tells us is that the multifactorial nature of things that can impact on older people. All these options are actually factors which will impact upon risk of undernutrition. So, and when you think about the complexity of care we need to provide in primary health care, these are all complex areas. So it's pretty hard to get it right all the time. Okay, so last slide, just look at your current understanding of treatment options and referral pathways for frailty, which can assist with reducing decline and helping people live at home independently. Okay, so looking as though we've got quite a few people that know some stuff, which is fantastic for our breakout room work. And we've got a few that are keen to get some more skills. So that's also fantastic. So we've got a lovely, lovely mixture of knowledge in the room tonight. Okay, well, let's go back to our presentation. Okay, and we've just done the housekeeping, done that. So we've talked about the speakers. So let's have a think. This is just our overview for tonight. And so these are the areas that we're going to cover. I'll cover a little bit about why this session. The fantastic Sue Kerr will talk about the frailty syndrome and frailty screening tools and present some evidence of making a difference. We'll work through a case study. And we're going to go into some breakout rooms. There are about 9 breakout rooms, so each of you will be doing some work tonight. Jane and I'll talk about some assessment tools to use in health assessments, and we'll look at some referral pathways for frailty, and then we'll get you home on time tonight. But what I want you to think about first is, why are we here? And so this is an ad that the Sydney North Health Network and the local health district are putting up on your TVs, and are going to go out to all the older people living in your community. So I'm just going to get you to watch this little clip. Okay, so it's not working. Okay, well, there we go. It's slowly on. I want you to think about, are you ready for this? So that is a real ad, and no, it's not going to be coming on the ad, but I want you to think, how ready are you if the people in your practices are actually going to be coming to see you and wanting to talk about it? and especially when there are many of the elements are reversible. We need to be here tonight because we have a rapidly aging community. We're all aware of that. Ourselves are included in that. So we need to really be thinking about how we can deliver different care to a group that is rising fast, wants to remain independent, and wants to be heard. Now, we've got a very stereotypical older person on our screen there, Mrs. Smith. And in the fragmented care network that she will often find herself, it's not easy for her to navigate, especially when she has mobility issues, sensory issues with her hearing, her sight. Clearly, mobility is limited by her osteoporotic back. She's a risk fracture. Many issues here, including her cognition. And it really reminds us about the Royal Commission recently. The Royal Commission to Aged Care looked at residential aged care, but it also looked at the issues in the out of residential care, in the in-home care. So all of us here on the call tonight work both in community as well as residential care. So we all need to be aware of what can we be doing differently as a result of the Royal Commission. I went to England in 2013 and heard the launch of the Francis report. Robert Francis was a commissioner into something called the Misstaff Inquiry. This great quote that he launched there was that care needs to be just as important as treatment, and older people need to be properly valued and listened to and treated with compassion, dignity and respect at all times. They need the skilled staff. These are pretty well the same words the two Royal Commissioners in Australia put into their findings. So all of us need to be aware of this. And when we look at the skills that we all have, a lot of them we've developed on the job. We can keep learning about how to deliver better care to older people. So tonight is about this. What are some of the things we can be doing a bit differently? Because we need to think differently about how we work with older people. Atul Gawande, who's one of my favourite authors, who's very inspiring, wrote this lovely book called Being Mortal about his experience with his father. He's a New York surgeon who traditionally writes a lot of interesting books about quality improvement. But this one was really from the heart about his experience thinking, what can we do differently for care of older people? So any of you that are online that haven't read it, I've certainly said it's a wonderful book to think about, and think about the lens of how we work with our older people, but also your own family members, because most of us are going to have people in our families that are aging and require better care. But his quotes from this book I want to get you to think about are really important and salient to tonight. Our ultimate goal, Atul says, after all, is not a good death, which a lot of us have talked about in the past, but it's actually a good life to the very end. We know that the difficulties that older people face, the most stressful and chaotic things in their lives are often compressed in the last 2 to 5 years. So what can we do to make that, the good life to a very end, be real for them? He also talks about this issue. We've been wrong about our job in medicine because we think so much about health and survival, but he talks about we need to enable well-being. And older people are often not given that opportunity to talk about well-being because it's one of the reasons you wish to be alive. And a critical discussion we really need to have is that what matters to you as an older person in our practice? Because often we get different answers that we're expecting with what matters to that older person. And that has an impact on their treatment choices. But often what happens, it's done in hospital rather than primary care. We've got to really make sure that we have these discussions in our out-of-hospital settings. But let's look at this. Now, all of you are clinicians on the call tonight. All of you recognise the trajectory of decline. So this slide helps us think a little bit about why we might need to actually do things differently. So if you think about your father, an older patient, someone that you know really well, this is what often happens. 5 years ago, they're talking about, you know what, I'm not as steady on my feet as I used to be. Then 2 years ago, the kids are saying, Dad's slowing down a bit. A little illness happens. This could be a UTI. It could be a COVID vaccination, a flu shot. something changes in their physiology, and their level of independence drops like a stone, and they become quite dependent. And we see this so often with older people, and then they make some progress, they get better from that shock to their system, and they become independent again, but not to the same level. And then it's this, he's a fall waiting to happen. So I want to challenge you all to think a bit about this, that where we stand back, why have we not done anything at the 5 years ago mark? Often what happens, we are treating people very reactively, and we get that to he's a fall waiting to happen. What difference could we have made if we had different conversations years earlier? So that's one of the conversations I want you to think about as a result of tonight's session. And the other take-home message tonight is about the Morley Frail Scale. Many of you said, hey, it's really, we're time poor in our practices. What can we be doing that is a really quick and straightforward way of screening for the risk of frailty? So John Morley, a geriatrician from St. Louis in the US, came up with this very simple conversational approach called the Frail Scale, where F is, are you feeling fatigued or tired? R is resistance, so it's resistance against gravity, body weight against gravity. Do you have difficulty walking a flight of stairs? Ambulation, do you have difficulty walking around a block? Do you have 5 or more chronic conditions? Or is there a loss of weight of 5% or more over the last 12 months? So these are the key factors of frailty, which Sue's going to explain a bit more to. And if you're scoring 3 or more, then you are highly likely to be frail, and you will benefit with some physical activity, polypharmacy review, looking at addressing the fatigue, and some protein supplementation. So we'll talk more about that as the session goes, but that's your take-home message for tonight. So how to actually think about a simple frail scale if you're not using one already. Some of the other things about why we need to be here, the evidence for some simple things like doing a 4-meter walking test. That walking speed predicts an older person's future far better than blood pressure. And how often are we actually doing this in our practices? How often are we measuring walking speed and saying, right, we need to be able to help this older person and make a difference there? Because in the end, this is what matters. Most older people are really aiming to remain independent. They want to stay there, and they want to stay there to the very end. One of the roles we have is to help them do that with dignity. So, and actually give them some empowered choices. So if we think about this condition of frailty and its context in healthy aging, we can all make a difference. So Sue, I'm going to hand over to you, and I'll get you to share your screen and tell us a bit more about the frailty syndrome.
So, yeah, hi everyone. Thanks for coming tonight. Hopefully you hang in the full, well, it's another hour and a half. So, yeah, I want to talk about knowing how to make a difference. And I'm going to start by asking the question, the very basic question, what is frailty? And just in a few words, it's age-associated decline in function, which results in an increased chance of poor health outcomes. Now, Chris has already said that, but I think what's important, and we'll talk a little more about that, is that people with frailty are 2 to 3 times more likely to use healthcare and have higher morbidity and mortality. And it covers everything, including more recently COVID. So going back to what is frailty, is this lady frail? So she's old, she's stooped, she's got grey hair, she's got visual problems, she's hanging on to the sink. And the answer is yes, actually, this lady is frail. What about this man? He's old, he's grey, he's skinny, he's slightly stooped, and you might say, yep, he looks frail, until you see this slide and you see that he has just set the world record for the 85+ marathon. Now, I challenge most of you here tonight to do a marathon in 3 hours and 56 minutes, especially when you're aged over 85. Is this man frail? Under all that fat, he is frail, and the walking frame does give you a clue. This is what's called sarcopenic obesity. So he's obese, and under that he's got loss of muscle mass, sarcopenia, and that results in frailty. So yes, he's frail. What about this older lady, the one sitting down? She's old, she's about 100, she's stooped, and you might say, yeah, she looks frail, until you see her doing this. This is Ruth Frith. She's no longer with us now, but she was an Australian who held the world, or still holds the world, 100-year-old javelin, shot put, hammer throw and discus. Not somebody to be messed with. So I guess what I'm trying to say is appearances can be deceptive. So how do we actually diagnose frailty? Chris has already mentioned physical frailty, the frail scale. And this is one of the ways you can define frailty, purely from a physical performance basis. And we define it as 3 or more of unintentional weight loss, self-reported exhaustion, so being tired or fatigued all the time, weakness as measured by hand grip strength using a dynamometer, slow walking speed, bottom 20% of your age, and low physical activity, which means you don't even walk to the front door, or maybe you don't even walk to the letterbox. So you're not doing very much. 3 or more of those, you are frail. We measure it. This is the Morley Frail Scale, all nicely tarted up. This is it. It's in our EMR. In Northern Sydney LHD, and it's also in a lot of GP management software, and it just operationalises what we were talking about before. The second way of looking at frailty is what's called the accumulated deficits model, and it's seen where you as you get older, you accumulate a lot of deficits, and this could be deafness, difficulty swallowing, heart failure, lung disease, high blood pressure, low blood pressure, that sort of thing. Excuse me. It's gender specific, seen much more in females, clearly related to mortality. And if you have more than 20%, you're, excuse me, it's not COVID. I was negative 2 days ago. You're likely to be frail if you've got more than 25% of the deficits. Now, I'll explain that. This is the frailty index. Have a little look at it and you can see why it's not the easiest thing to measure. A lot of deficits. So if you've got more than 25% of these, and you can see you've got tremor, you've got breast problems, all sorts of things, but more than 25%, you're frail. But this is more, I guess, a measure of comorbidities than actual physical frailty. So we tend to go with physical frailty. Another way of looking at frailty using that accumulated deficit scale, and this is actually quite a popular scale, is the clinical frailty scale. But I've already said appearances can be deceptive. And unfortunately, the way this scale is used is that people simply look at the pictures. They don't read what's in the text beside the pictures quite often. But this was the scale that was recommended as triage for older people, whether they would go into ICU or not, if they had COVID in the NHS. So people were being triaged on this basis, and it really worried a lot of us, because when you see someone who's almost at death's door, they're going to look like a 7 or an 8, whereas they could well have been Ed Blacklock, who was the marathon runner. But I can tell you, if he's in a bed in a hospital gown, he would look pretty dreadful. So we do need to be careful how we use these scales. So how common is frailty? In New Zealand, in the acute hospital adult population, so that's over 50 and older, it was about 49, 50%. In the Australian community, in an Adelaide study, so this is Chris and Jane's bailiwick, about 21% were frail using the physical frailty measures, 48% were pre-frail, which means they had 1 or 2 of those criteria. We know in the European community over 65, again, using physical frailty, 17% of older people are frail. In our studies in Hornsby, looking at medical inpatients over the age of 75, 55% were frail using the frail scale. From a recent international systematic review and meta-analysis for over 50-year-olds, and it's always annoying because everybody uses a different age cutoff, but over 50, and that's quite a few of us here tonight, 12% are physically frail and 24% are frail if you use the accumulated deficits model, so that the more things wrong with you, the more likely you are to be frail. And it's very interesting because we've been talking about frailty, well, for more than 20 years, but it's only just coming into clinical practice. And we're doing screening, we're doing intervention, both in primary care and in hospital. And it's really great to be part of that. The Lancet got onto the bandwagon a bit under 2 years ago, and in October 2019, they had a series on frailty. It was actually only 2 articles, but they're 2 very good, very comprehensive articles, pretty dense. But if you want to know a lot about frailty, they cover it. And they were written by a number of experts across the world, looking at the different ways of measuring frailty. And I guess this is the most important slide. I know it's really busy, but why don't you want to be frail? And think of that graph that Chris showed, where suddenly you drop off and you drop below the independence line. We know that if you're frail, you're more likely to end up in hospital. You're going to get post-operative complications after a whole lot of different sorts of surgery. And there's very good articles looking at all of these. You're more likely to get a UTI, pneumonia, DVT, either in or out of hospital. Interestingly, you have an increased risk of developing COVID pneumonia and 2 to 3 times chance of dying from COVID infection once you've got it. So being frail and not being vaccinated for COVID, we hear the results every day of older people who are frail, who are dying from COVID. If you're frail, you stay longer in hospital, you're going to go downhill functionally, you're more likely to end up in nursing home. If you're frail, you're more likely to fall and you're more likely to fracture. Interestingly, and this scares a few older people, you are also much more likely to develop Alzheimer's disease if you're frail. And there's a very interesting link between frailty and dementia, particularly Alzheimer's disease. And we know if you're frail, you're much more likely to develop Alzheimer's disease. And if you've got Alzheimer's disease, you are likely to become frail if you're not already. And what is very interesting, and it's only been published very recently, was that if you get 5 out of 5 on that frail scale, you have triple the risk of death of someone with 2 or 3 out of 5. In other words, it's pretty difficult to come back from the edge if you've got 5 out of 5. So I think we really need to be thinking about that graph of Chris's again and ask those questions and have those conversations much earlier before they get to 5 out of 5. This was an article a couple of years ago in Age and Aging, which is one of the journals for geriatric medicine. And it was frailty, not age, that predicts outcomes of emergency surgery. And I think that's really quite interesting. And therefore, I mean, you can't do much about frailty if it's emergency surgery, but if you've got elective surgery, you've got an opportunity to actually get someone a little stronger before they have that surgery. And we're seeing that's working quite well. And it's called the Holy Grail project at North Shore. And they're looking at picking up these frail older people and giving them a burst of physiotherapy, nutrition, checking their polypharmacy, those sorts of things to get them as good as possible for their elective surgery so their outcome's not so bad. We've certainly seen positive results from other countries doing that. We also know if you're frail, you're much more likely to die from cancer. And this is an older study, but it really is a bit of a pivotal one. Just looking at people, I think there were 3 different sorts of cancer. 9% were frail, almost 40% were pre-frail. But if you look at the survival rate over 10 or 11 plus years, the non-frail lived for 14 years, the pre-frail for 9, and the frail for 2.5. So again, frailty is really important. And a lot of people say, well, so what? They're frail. There's nothing we can do about it. And I think that's absolutely wrong. We can do something about frailty, and that's what I'm going to talk about now. We know that frailty is a dynamic state. People move in and out of it. They transition between frail and pre-frail and non-frail. And we can prevent it, get people at the very start of that, of Chris's graph and curve, but you can also treat them and treat them effectively. And there's several evidence-based areas of intervention. Physical activity, particularly resistance training, is really, really important. Also aerobic training and balance and coordination. But resistance training is very important. Nutrition, and that was one of the questions that was asked. Older people need 1.5 grams of protein per kilogram of body weight per day. Younger people, most of us here tonight, need 0.8 of a gram of protein per kilogram of body weight per day. So older people need double what we are eating almost, but they don't. Older people, as you know, tea and toast, sandwiches, soup. So it's really, really important that we look at the protein intake of our older patients. And I'm a big egg person. I tell everybody to add 2 eggs a day. It doesn't matter if you have them for breakfast scrambled, you can put them in an egg flip, you can hard boil them and have them in sandwiches. But eggs, about 13 grams of protein in each, is a good way of getting some protein into you. We know that multi-component interventions are important, which is basically physical activity and nutrition. And we'll come to the polypharmacy in a minute, and individualised geriatric care, which actually targets the clinical conditions. So the evidence tells us we can do something. I just tell you about a trial we did 10 years ago in Sydney called the Frailty Intervention Trial. 241 frail older people living in the community. Frail on 3 or more criteria of the physical frailty, and they were randomised to an intervention which was basically exercise and nutrition or usual care. We looked at them at 3 months and 12 months. We used something called the short physical performance battery, which is basically chair stands, walking speed and tandem stance, which is ability to stand with one foot in front of the other. These are some of our participants, coordinated in clothing, who were doing exercises at home. So using, other than the wedge we gave the lady on the left, using things at home. And this is what we showed, and this is almost the only graph I will show. On short physical performance battery, which is out of 12, the intervention group in red made a bit over a 1-point improvement. So it was about a 10% improvement. Now that was very much statistically significant, but it was also physically significant if you think of it over all those people. But a picture's worth 1,000 words. So I think I will just show you a before and after of one of the participants in that study. So this lady was quite frail at the start, and you will see we ask her to get out of the chair. And you can see her, it's quite hard work getting out of a soft lounge, and that's certainly the situation. She had 4 criteria on the physical frailty scale. So I'll just close that and move to the next one. Sorry about the writing in the middle. I shall try and get rid of that. After 6 months, same lady, same task. We said, ready, set, go, and you can look at her get up. And you can see just that little smile on her face. Now, she was no longer frail, only on grip strength. But what was more important than just being able to get out of that chair was that she could go up a flight of stairs. She could go to the train station, get on the train. She could go to book club. She could go to church. It made a big difference to her life, getting her less frail. In fact, she was pre-frail. So how do we put evidence-based guidelines into practice? And we do have evidence-based guidelines. The Asia Pacific Clinical Practice Guidelines for the Management of Frailty were actually published in 2017. They're called Asia Pacific because the consensus meeting was actually in Singapore, but it had people from all around the world. And there was pretty good agreement on what you can do about frailty. And there were 6 recommendations. 3 were strong because they had a lot of evidence behind them. The first was use a validated measure to identify frailty. Frail scale is one of those. Prescribe physical activity with a resistance training component. Address polypharmacy, which is really important in our older people. And then 3 with slightly less evidence, but still very strong. Screen for and address fatigue. So why is the person saying they're tired all of the time or most of the time? Are they anemic? Are they hypotensive? Are they depressed? Look at what is going on. Address weight loss with protein calorie supplementation. And you can see the proteins, the first word there. I've already said why it's so important to get a fair bit of protein into older people because they need it much more than we do when we're younger. And then a very simple one, prescribe vitamin D if they're vitamin D deficient, if their level's below 50. And with so many people wearing long sleeves and hats and sun cream, we are seeing a lot of vitamin D deficiency. And from my point of view, an older person, certainly a person over 80, unless they're living in the country and getting outside a lot, they will be vitamin D deficient until proven otherwise. So that brings me to the Northern Sydney Frailty Initiative, which was a combination or a collaboration between the Primary Health Network, Sydney North Primary Health Network, and Northern Sydney Local Health District. And we came together in, it was 2017, to look at frailty in Northern Sydney because we have an ageing population. 25% are over 70 and there's a lot that are frail. You're looking at maybe 26,000 older people out there who are frail. We started by screening using the frail scale in the acute hospital wards. And then we looked at interventions and we actually screened well over 1,100 patients. And if they screened positive on the frail scale for not being able to go up a flight of stairs or walk, that was a referral to the physiotherapist. If they'd lost weight, it was a referral to the dietitian. If they were on a lot of medications, it was a referral to the pharmacist. And we don't have very long when people are in hospital, so we would do the screening, develop an intervention, but then we looked at handing over to the general practitioner. And this is not fobbing off, it is handing over with some suggestions. And the Primary Health Network have done this amazing job on developing resources for older people who are frail. And the concierge, the concierge service we'll talk about later, the care navigators will really, really help with that. We are about to start an NHMRC funded research project that I think has been briefly mentioned, to continue this study and do more evaluation out in the community. But it's basically screening, assessment, and referring to the appropriate services. We know that frail scale is happening in general practice, which is just fantastic. There are KPIs, there are a number of practices involved, and it's so good to see that we are really starting to get the message out there and that you really can make a difference in terms of frailty. And there is a primary care management tool. All that information is on the website. This is the primary care management tool, which you can see if you go down the left-hand side, if they've got a positive score, exactly what you do. And it's certainly, that's available on the website, the Healthy Aging and Frailty website, which hopefully you're all aware of, and that's this one. It's got lots and lots of information on it, and I think it's really, really important that we let our patients know, as well as all of us being aware of what's available. Finally, and I'm running well to time here, or well under time, I just want to look at a different way of looking at a frailty intervention, or two different ways. And I don't know how many of you saw Old People's Home for 4-year-olds, but basically that was a pre-post interventional study of frail and pre-frail older people living in a retirement village. They were either in independent living, or quite a few of them were in supported accommodation. There were 11 older people. Their mean age was 87, so they're certainly not youngsters. The oldest was 95. He's now 97 and still going strong. The primary outcome in this study was walking speed, hand grip strength, and tandem stance. So the ability to stand one foot in front of the other. So balance was very important. The intervention over 7 weeks was simply interaction with 10 4-year-olds. And it was amazing to see the difference that those 10 4-year-olds made to those 11 older people. There were clinically and statistically significant improvements in all primary outcome measures in everyone, which is pretty unusual for a study. I know it wasn't randomized, but it certainly did show the improvement. And I think what's really good is that that improvement continued from late 2018 when the series was filmed, although it didn't show till late 2019. A number of those people are still active, and last Christmas, I think 5 of the children's families had older people from that group coming to visit. And the other nice thing was we won an international Emmy for it, which is the equivalent of an Oscar. And I figure there's not many people that can put that on their CV. But it was pretty incredible that a series with no sex, no violence, no bad language would attract that much attention. And it really was a great series. We did that in residential care, but we thought the vast majority of older people actually live in the community. So series 2 looked at 11 older people living in the community, and that's the group here. And you can see mean age was 85, so 2 years younger than the residential care group, and their age range was a little wider, 76 to 94. And once again, the intervention, only this time it was 6 weeks, not 7, because we were trying to fit it in between COVID outbreaks, and amazingly we did. But the 6 weeks of interaction with 10 4-year-olds. And again, there were a number of primary outcomes that were similar to the last one, but we actually looked very, very carefully. We did the frail scale before and after and measured things a little more, well, just more measures. And what we showed when we looked at all the measures and we looked at depression and quality of life was, again, overall improvement in all the primary outcome measures, with all the participants improving to some degree, but particularly on frailty, so on the physical side of things, and on quality of life. And we know that 6 months later, the effect was still sustained. We haven't been able to do a follow-up for obvious reasons over the last 3.5 months, but we know that the interactions between children and older people are continuing. Now, I realise we can't dole out 4-year-olds to every older person to get them doing things, but I think it's important that we think about how we can take some of those principles and get older people more engaged in the community and with each other. Now, clearly COVID has totally put the kibosh on that at the moment, but I think we must be remembering what we can do. Finally, I want to say that it is never too late to start. And this was an editorial in February last year in the British Medical Journal. Unfortunately, it came out just as COVID was taking over our consciousness, and I don't think a lot of people actually saw it. But I think that the bottom 3 lines are really important. Skeletal muscle remains a plastic adaptable tissue throughout the human lifespan. It is never too late, and you are never too old to start contracting your muscles. And I think that is a really important message for us to give to all our older patients and to our younger patients, because if we build up our muscle mass right through life, you've got a lot more to lose near the end of life before you actually have functional problems. And I finish with some more pictures of the wonderful Ruth Frith. You've seen her throwing the javelin. You can see her here with hammer throw and shot put. She really was a pretty amazing lady, and I think a good example. She started training at the age of 75. She was a sort of a couch potato, as she describes herself before that. So I think that's a really important point to end on. And at that, I will say thank you, Chris, and hand back to you. I'll stop sharing my screen.
Great. You have done so well, Sue, with that timing. So exceptional. So what we'll do is we'll now go into a little bit more depth of a case study where Jane and I will be more involved with you. But we're going to introduce our friend Sam. And Sam is a key part of tonight. And we hope many of you had an opportunity to read the case study about Sam, because one of the dilemmas about doing this in the virtual world is that the information on the slide is going to disappear in a moment. So that we're hoping that you've actually had a chance to review Sam. But let's just take him through. Now, he lives at home with his wife. He's a retired mechanic, and he's pretty well in that age group that Sue's just talked a bit about, that 86, frailty is highly prevalent. But he's coming along regularly for his checks at the GP, and he's very, very fastidious about his lipid levels and his blood pressure levels, because that's been such an important part of his earlier life, to make sure he reduces the risk of having a heart attack or stroke. And he's got osteoarthritis. He's also developed some early Alzheimer's, but he's functioning well and is still trying to get out and about and do things. His current cholesterol is up there. His EGFR is 49. And for those of you that are eagle-eyed and know a bit about chronic kidney disease, it's stage 3 chronic kidney disease, and an important element when it comes to working with older people. He's been a smoker but doesn't drink alcohol, and he stopped smoking about a year ago. So we know that that will be a risk factor as well for COPD. So this is his typical team. He comes to see his GP regularly for his basic scripts and vaccines. There's a practice nurse in his at the practice he goes to, that he comes in because he wants his podiatry. So he knows he's got to see the nurse for his care plan. The practice also employs another nurse on a contract basis that does home health assessments, and he gets seen once a year for that. Pharmacist, unfortunately, his wife will often pick up the scripts, so the pharmacist doesn't really know Sam too well. He's got his favourite podiatrist, sees him regularly for his toenail and corn care, because he just can't reach down, can't see his nails anymore to safely actually attend to them. He's got a neurologist that catches up with him a couple of times a year for his dementia, a urologist for his bladder symptoms, and he has just sees a dentist, but doesn't see him very regularly at all. He's only got 20 of his 32 remaining teeth, so he has lost a few over life, and with his smoking history certainly has a risk of poor oral hygiene as well. These are his current medications. As you can see, it's a very unhappy looking list for many different things. So we're going to be taking you through this, and hopefully you've had a chance to read this, and because I don't want to go through every medication tonight, because we want to get to the what are we going to do. So Sam is due for his annual health assessment with the nurse. He gets his recall letter, and his wife calls the practice to book that time. Practice nurse visits Sam and says, look, I'm pretty good. I'm my usual self. That's what he says. But Sam's wife indicates otherwise, that he's no longer leaving the house, he's lost some weight, and that he's had a number of falls. And actually, in the last 2 weeks, these falls have been increasing with some, fortunately no fractures, but he's had some bruising and scrapes. And she lets know that this seems to be occurring, these falls and this sort of reluctance to leave the home and losing weight, since he spent some time in hospital where he had surgery for his enlarged prostate. He ended up having a catheter in for a bit longer because he had a UTI back then. So he spent around about 9 days in hospital, which is longer than the usual time. So then he was discharged home. And the nurses examined him, found that, okay, so blood pressure's fine, pulse and no fever. SATs are good. So what we need to do is think about, all right, all of you are in Sam's team. You've been put into breakout rooms for a purpose because, you know, managing Sam and his cohort of friends is a team game now. We need to think about this through a multi-dimensional lens. So how alert are we all to the functional issues and the medicines issues which Sam has? So in your breakout rooms that Robbie is going to put us all in a moment, we're going to really think about these concerns. What can be offered? But the big questions that your facilitators in your rooms are going to get you to think about. What's actually happening to Sam? How would you assess from your particular discipline of healthcare's lens what could be done to avoid Sam from becoming more dependent? Because he's on that pathway that we talked about, that trajectory of decline. What can we do to help him actually change that trajectory? What deprescribing should or could occur? And what are the referral options to keep Sam well at home and out of hospital and out of residential aged care? Because that's where that trajectory goes. So let's look at room 1, and that's Diana. It's your room that I'd like you to start off with some discussion about what you had an opportunity to talk about and how would you assess, what you all thought was happening and how would you assess Sam and your ideas about how you make a difference to Sam.
Sure. So Jennifer picked up on the deconditioning from the hospital visit and also flagged the continence with the prostate surgery. What the group recommended was definitely resistance training and mobility training, looking at the continence, having a cognitive assessment, and also looking at that polypharmacy. And a dietitian, and the dietitian was a number of things. So looking at the cholesterol, the weight loss, kidney disease, and also the constipation. Is that covered all from the group?
That's pretty good in about 2 seconds flat. Well done. Okay. So very good. All right, let's go to room 2 and Yog's room. What sort of reflections occurred from your room, Yog? What did everyone think was happening to Sam?
Yeah, so I think the group sort of collectively, you know, one of the things we were wondering was around his cognition and the fact that he's been in hospital recently. So whether, you know, there's a resolving delirium, maybe he's got a mood disorder, or, you know, he's obviously got dementia, whether there's a progressive nature to that. And the falls we were sort of focusing on around as well with his history of osteoarthritis. So there was some talk around the medications, and, you know, he's on some strong opioids and whether they could be reduced, and the physiotherapy program assessment and a pharmacy review to look at some of you know, the benzo that he's on for sleep at night, which, you know, we were just talking about how that can be quite challenging sometimes to wean patients off, but, you know, it is associated with falls and a lot of other issues. So looking at some safer alternatives like melatonin potentially, and we talked about some of the anticholinergic effects of some of like the medications for hay fever and his continence, which, you know, can have impacts on you know, cognition. And then we briefly, I think the time sort of went a lot quicker than we expected, but we briefly were just starting to talk about, I guess, you know, how an OT assessment might also be quite useful here to do a functional review and maybe a home safety assessment.
Excellent. Okay. And I think we've got time for one more group. So we'll look at, where am I? Dina Faraj, your room. What did you...
So very similar to Yog, our group were quite concerned about his medication regimen. We felt that it was quite an extensive one, and a pharmacy review would be really suitable for him. We also thought physiotherapy would be really suitable for him, perhaps with a bit more of a direct referral pathway. And I think the big consensus there is that we'd love to know how better to refer. That was a big consensus in the room. But also other things that we thought of were ideal for him is to understand his goals of care. And if he particularly wasn't sort of keen on doing more, also understanding what the goal of care from his family might be. Dietitian was thought is really quite important because of his weight loss and cholesterol. And again, just to summarise about the fact that we felt that we needed to know a bit more about how to refer, or what are the referral options, in optimising somebody like Sam.
Okay. Right, from Maylene's room, anything else that we'd like to add that hasn't been said already?
I think lots of what we covered has been covered, Chris, in our room. However, we did have a dentist in our room and a speech therapist as well. So they brought in some interesting perspectives about how some of the medications might actually lead to issues such as dry mouth or chewing difficulties, swallowing difficulties, and that could be linked to his weight loss issues. And also the fact that having the dementia or the Alzheimer's disease is progressive. And so as that progresses, he could have dysphagia and other conditions that need to be reviewed. But certainly the physiotherapy and occupational therapy and just making it a more multidisciplinary approach to addressing his many issues was discussed, and polypharmacy as well, as everyone's mentioned.
Yeah, so I guess that it comes back to, I think many of you mentioned, what are the referral options? How do we actually do this? So it probably is a good opportunity to actually introduce Yoga and the Jerry to GP program, because I think you've got quite a few things that you potentially could offer, Sam, and it's something I think that when we hear and work with our sort of colleagues, they go, these are some things we can actually put into everyday practice, as well as understand how to refer people. So, Yog, I'll hand over to you to sort of go through a few things from a geriatrician's perspective.
Thank you. Yep. So, hi there, everyone. I'm Yog, one of the geriatricians from Hornsby. So, I guess I'll briefly just mention what the geriatrician outreach for general practitioners is. If you can go to the next slide. So I guess just a brief outlook of the model. It was following a lot of extensive consultations with GPs and clinicians in Northern Sydney. There was a desire reported by GPs to essentially have access to a specialist, a geriatrician, to help manage patients, not at the point of deterioration, but prior to that, when things may foreseeably take a turn in months down the line. So now, as a result of that, there's essentially now a free, dedicated local geriatrician to help support, and advise on the management and planning of patients who are older and frailer in the community. And next slide. So this is just a bit of a busy slide, but in Northern Sydney, there's different geriatricians across the various hospital area networks. So myself in Hornsby Ku-ring-gai area, we've got Dr. Linda Zhu, who I think might be part of the attendance today, but she's working out of the Ryde area, and we've got Dr. Praveen in the Lower North Shore area. For the Beaches area, we've got direct contact with Dr. Gillian Meyer, who's running the GEM unit, and it's no complicated referrals. It's just a simple call or email, and so those are all our direct mobile. So you sort of have access to us, whenever you sort of need to ask and getting advice around. Go to the next slide. So I guess the question is, what type of patients are suitable? And, this is just a brief, looking at patients 70 and over. Common things include medication management, frailty, dementia, cognitive impairment, falls, depression. And, if you have a look at that, so Sam is kind of a great, a stereotypical kind of patient that we would often see and advise on. And I guess how the program looks is on the next slide. Chris. Well, actually, so there's how to screen and identify patients. So, there's various different ways. So, using practice data to extract patients who are high risk. patients who are recently discharged from hospital. I think that everyone's really busy and focusing on the vaccine. That's a great opportunity to sort of screen and identify patients who sort of, only come once a year or haven't been to the clinic in ages, and things may have sort of changed in that time period. During 75 plus assessments, and also those identified as frail with the top bar screening. So there's no complicated referral, and how the model works is really up to each individual clinician, and there's the opportunity to sort of just call and get some ad hoc advice. If we don't pick up, you leave a message, and one of us gets back to you. Often if we're in a family meeting or something, we'll call back as soon as we can. Or you can book a time and we can go through patients. We can book out 15 to 30 minutes and go through a few patients together. There's also the opportunity to sort of do a lot of telephone or video conferencing at the moment. And prior to COVID, we've also doing a lot of in-person assessments, whether it's just us and the patient, or whether we do it simultaneously with the GP, including both home visits or nursing home visits as well, if required. You can submit via email questions and we can get back to you. Or we've also been able to come out to GP clinics and do a little bit of education sessions around certain topics that might be of interest, and that sometimes sparks conversation around patients that they might have, and sort of we can discuss that. Next slide. So I guess just briefly on the experiences I've had in Hornsby, it's been running. We've sort of started at different points, but around April to May onwards is where the majority of Linda, myself, and Praveen was sort of online with this service. So it has been around for about 3 or 4 months now, and it's been in various different forms. Some examples, again, is telephone discussions. So there's been countless of those, just brief discussions around polypharmacy, about when it's appropriate to stop some things like statins, how to manage some medical issues like hyponatremia, or someone who's dizzy and falling in the clinic, or just advice around someone who's recently been discharged with delirium. We've done clinic reviews. We've all sort of, sometimes had group bookings in GP centers where we come out and the GP, the clinic sort of brought in 3 or 4 of their frail elderly patients, and, issues from frailty to cognitive decline, functional decline, or cognitive assessments, or falls assessments are some of the common things we've done. And we've also done, home and aged care visits to follow up patients who've recently been discharged, or, patients that GPs are worried about. I guess that's sort of how the service has sort of worked, and it's been sort of tailored to each individual clinic and how they've sort of found it useful. And it's sort of in the early stages, but the referrals are getting it's getting busier, and then we encourage anyone to sort of if you're working at a GP clinic or you are a GP yourself, then definitely sort of reach out and let the rest of the GPs in the clinic know as well about the service. And that's all our numbers there.
Okay, so maybe take some screenshots, everyone, if you then can follow up. That is an outstanding service, Jog, and I wouldn't be surprised that you'd be overrun very quickly with questions and queries with the number of older people that are in the Sydney North area. But as a GP, again, it's great to have a number that I can call. Older people are my special interest, so I certainly see a lot in my practice, and so we've learned to sort of do a lot of good things within our practice, as far as do the medication reviews, get the pharmacists on side, got the nurses working on the 4-metre walking test, doing the mini mentals, doing the geriatric depression scales. And so we're doing those sort of screenings. So when we look at the assessment of someone like Sam, we're picking up a lot of information early on to try and work out what's happening. I wonder whether there was a particular thing that we should take away from tonight from you, that one of your favourite assessment tools for someone like Sam if he was presenting to you.
Well, I mean, I think with the whole so when I was in sort of around the frail scale, I think that's a great one, because it sort of gives you those it's a bit of a cheat sheet, because it's got multiple assessments inside of it, and it's also got plenty of options and discussion pathways that you can sort of refer to, and it sort of helps guide you towards getting a pharmacy review, getting an OT assessment. So it really is a great tool that I think and it doesn't take very long to do. It's only really 5 simple questions, and it sort of gives you a really good picture on the patients. Yeah.
It's good. I think our breakout room sessions with all the different disciplines has actually been really good, that bringing the different lenses of the team to actually assess Sam. But clearly, walking into someone's home confronted with this sort of undifferentiated and really quite complicated area. The good thing about someone like Sam is it's not actually an emergency. In the fact he doesn't need to be going to hospital. We can tackle it bit by bit. And I think when we look at someone like Sam, the deconditioning is a critical button. And in our session, we had Anthony, who's an exercise physiologist, and really critically said, look, the dilemma for someone like Sam is even mobilizing to get out to an exercise program. So in-home exercise is something we've got to all get a bit better at actually being able to prescribe, because often that's going to be the bit that gets him mobile to make a difference. His aims are critical. What's his goal? So we can actually then get something happening, because it's not much use if he's not going to be able to get out and about and do much else. So Jorg, thank you for your input. And I'm hoping that we'll see a lot more of what you do. So we're going to look a little bit more about what else can we do making a difference in primary care. And you can see Jane's pictures there in action in her healthy aging clinic, going to see a lot of the Sams and the Mrs. Browns of the western suburbs of Adelaide. So as a primary care nurse, Jane, it's great to see you in action there.
Yes. Yes, in the first picture, we're doing a 4-metre walking speed out the front of their house. And then the second picture, I'm working with the elderly gentleman doing his, he's showing me how he uses his exercise bike at home. And then the third picture is what we want to see our patients doing. It's a bit of a joke.
That's right. Well, no, that's not a joke, because that's something that, they can have home-based exercise programs where they can have little weights and they can do their sit to stand. So these are things we need to think about in practice, because many of you go, well, some of the barriers are time, but actually, and some of you put up earlier, the barriers is money. People don't want to pay for an OT service, don't want to pay for a dietitian service, don't want to pay for an exercise program. So we've got to think laterally, how can we get more people doing these things? In the end, it comes back to what home exercises can we teach people? And Sue's frailty intervention research certainly showed it does not have to be really, going to a gym and doing it all there. You can devise simple exercises at home. So what we're going to look at next is just what else can we do? So we're going to run through Sam as a little case study, and this is Jane and myself role-playing Sam and the nurse. So we're just going to spend a few moments watching this and looking at the assessment.
Hello, I'm Jane. Remember you saw me last year when I came out to your home about your health assessment, but you didn't really want me to come? No. Well, anyway, sit down, Sam. We'll have a little chat. Sam, your wife told me that you're not wanting to go to the bowls club as much.
No.
What's happened, Sam?
Oh, I just don't have the energy, don't have to get up and go to go and do it. I'm just tired all the time, and I just can't do it.
So, okay, Sam. So you're saying you're tired all the time. Are you able to walk up any stairs, the stairs to that bowling club?
No, that's another reason why I can't go and see my buddies, that there are stairs there. And, even, 4 or 5 stairs, like I used to be able to go up there, no problems, but I just can't do it anymore.
And how far can you walk now?
I can't even walk down the street to the newsagent to get the paper.
Oh,
so really, I'm struggling.
All right. And what about, we'd actually like you to come back into the practice soon. The doctor wants to go through some of your medications and things, but because you have got a number of illnesses, have you felt as though you lost any weight?
Yeah, I'm just the belt's getting pretty loose now. Just haven't got the same appetite like I used to have. Okay,
well, I would actually like to just see you walking, because I think that would be just a good test. I've got a couple of other things here today. I've got a grip strength, and I'd like to actually measure how you go with squeezing this as hard as you can. and then we can do it again when you're in the surgery, have another look at it. So I'll just turn that on and squeeze as hard as you can. Good. Oh, yes. It's pretty hard, isn't it?
Yeah, that's not easy.
No, no. Okay, well, let's do the walking test. Now,
What do I have to do for that?
well, I want you to stand over here, and then I'm going to stand over.
Where do I have to
this way.
stand?
Well,
Is that a marker?
I'll come with you.
Right.
Okay. So, Sam, we'll just stand there. And when I say go, I want you to walk towards me. Now, I have a marker here about 1 metre from Sam's feet. And then I've got another marker 4 metres down this way. And when I say go, Sam, I want you to walk towards me. Ready, set, go. Okay, 1 metre. Now I start marking how, timing him, seeing how, oops, yep, okay. All right, that's pretty good, but we might have another try in the surgery next week. All right. Oh, yes, 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 yes. Okay. I'm going to have a little chat with your wife, and
What do you want to ask her?
well, she might just fill me in about what you're eating and things like that.
Yeah.
Anyway,
Yeah, she'll tell you that I haven't been eating like I usually do.
you've lost your appetite. Yeah. Okay. I have brought some samples of some protein powder that you can have in your drink after lunch. And I might give her a sample of that and you can try it. And if you want to get something like this.
Why would I want to have protein?
Oh, well, sometimes as we get older, we need a lot of protein in our diet, and it is harder to have. You're probably not eating as much meat as you used to. No.
My teeth don't fit like they used to.
No, no. And so we want you to have meat, fish and eggs in your diet for the protein, but sometimes you need a bit more. And so a lot of patients I work with, quite like a drink of chocolate sustagen after lunch, and it does help fill you up a little bit.
Okay.
Anyway, that's probably it for now.
All right. And you had a chat to my wife, I understand.
Yeah.
What did she tell you?
Well, she said you actually had a fall a couple of weeks ago.
Yeah. Is that what she said?
Well,
only one.
Yeah. And you're not quite as fast at getting up off the chair.
No.
Well, we probably could improve that, but let me go and I'll talk to Dr. such and such, and we'll get back to Dr. Chris, and we probably can come up with a bit of a plan for that.
Okay.
So.
And did she tell you about me being in hospital?
Yes, I did hear that. Yes, and that was a good idea to get me out for the health assessment, because once you've been in hospital once, there's a good chance of you having to go back for another reason. So we want to keep you out of hospital.
I don't want to go. I was in there for 8 days. I had that terrible bag thing on my leg.
Yes.
And I don't want to do that again.
Okay. All right.
And they didn't get me out of the chair. I was in bed for 8 days.
Oh, yeah, no, it's very... I think it's time to go back to the surgery now. Okay.
All right. So...
Okay, so what we'll do next is I want you to get into your breakout rooms. So Robbie, if you put us into breakout rooms, and we'll talk about the barriers. What are our barriers to the issues of frailty that we confront? What are our barriers to recognising frailty, and what will we do about it? So if you put us into our breakout rooms, we've got about 5 minutes just to chat about our barriers. We talked a bit about it earlier, time being one for many people. But what are you going to do about it as a result of tonight? All right, so thank you very much for challenging yourselves to think about your barriers. So what I might do is, Annie, let's have a hear from your room. What barriers did your group put up, and what did they come up with any solutions that they might be thinking that might overcome their personal or professional barriers?
Yeah, thanks for that opportunity. So we had a chat about a few of them, and Philip came up with a few things that may be barriers, and that was, for instance, resources and education, and maybe some limited understanding of frailty in the community. And he said that while he works in the hospital system and he finds that, you know, referral pathways are aplenty for him, he's able to refer to physios, dietitians, OTs and the like. But when he's maybe working outside the hospital, his biggest barrier would be time, to actually have the time to make those referrals if he had to search for them. So I thought that was pretty interesting feedback. And I spoke to Elaine, who's a nurse, and she said, unfortunately, she doesn't always see clients like Sam on a regular basis. Maybe they might pop up once a year with a care plan. But for her, you know, obviously her first port of call would be to go to the GP and to discuss how they'd best address this, would address someone like Sam from a holistic perspective, and together they would address any barriers and share their resources to go about providing a complete holistic, you know, situation for someone like Sam.
Excellent.
Is that what does everyone agree with that in group 5?
Yes, Annie.
Very, very good. All right, thank you, Annie. Okay, what about Hema? You had room 6. What were some of the reflections, the barriers in your room?
Yeah, so look, we had a group just with allied health. So we just had that perspective. So one of the things that they noted was that really in the practices, they don't have an official sort of assessment tool that they're using, a standardized process. So I think they're looking at perhaps introducing something like Frail Scale, and also being able to work with the full allied health team to look at the possible interventions within that. They also said that when patients leave hospital, it's sometimes difficult to sort of figure out the referral pathways and how to continue the work that's already been done. And so looking more broadly at who else needs to be involved and really developing that sort of team around them is key. And that referral keeps coming up, actually. And I think that's a really difficult area. And I think the third one was patients lack motivation, and that's quite difficult. So finding support pathways to really help them to want to get back on the path again.
Yeah, and the key part there is actually finding out what their goals are. And I think that's sort of sometimes when we're time poor, we'll often tell people stuff. This is what you need to do. Now that's not going to motivate people. Yeah. If we don't find out if we're not engaging with them to work out what their goals are, what they want out of life, and then challenge them that to get there, they need to be doing some stuff. So I think that's a really key point there.
Yeah.
So thank you.
Where they all fit in with allied health and so on, the team. So I think that's really important. I hope I've covered everything, group 6.
No worries. All right, we'll move on to Taylor and group 7. What sort of reflections did you have from your group?
Yeah, we've mainly focused on the barriers, and the number one, which has already been mentioned quite a bit, is time. I think the other aspect of time is also prioritization. It's about what's a priority. So often with someone, if they're having a consult in front of you, they've generally got a series of priorities, and so do you. And so maybe frailty isn't always at the top of that list, not without a sense of urgency. Sometimes it's not necessarily brought up by the patient themselves, but maybe by the family, particularly if it's in a family practice where the practitioner has been taking care of not only that person, but the other members of the family. It might be brought up by them. But also then that just lack of patient awareness, but also some resistance from the patients. Maybe they might be resistant to you discussing the topic that they are getting more frail. Maybe they're a bit more self-conscious of it, or it's not the easiest topic to discuss or raise with people if they might have some resistance. I think that's the summary from our room.
You just brought up a very good point there, because yes, the majority of people are not going to be very accepting of being called frail. So what we've got to actually think about is the use of our language. that, you know, and I guess the concept of healthy aging is so important. But really, just simply getting back to some of the tin tacks of what's happening in their lives and what can't they do anymore, is the clarity of being able to get them to articulate that. And so from there, you know, I guess from a clinician's head, yes, we're thinking about frailty. The person doesn't necessarily need to know, hi, I'm frail, but it's about what is it they can do. We'll talk a little bit about that in a moment. But thank you very much, Harrison, for your reflections. It's very, very good.
Taylor. That's right.
Taylor.
It's all right. All good.
Okay. Last but not least, Sue, anything else from your room that you want to add?
Are you on mute, Sue?
Yeah, no, I was just trying to find the unmute button. Look, everybody's mentioned it, the patient being resistant. One thing to add is that the voice of the GP is very important. And so actually, if the GP says, I'd really like you to do this, that's important. One of the positives, an enabler was Zoom and telehealth, that it does keep the costs down because cost wasn't seen as a barrier and transport was seen as a barrier. Bringing people in when, and of course, home visits are very expensive. And a lot of older people will pay for the plumber, but not for a home visit from an OT or a physio, so, or an exercise physiologist. So I think those were the extra things that we could add. Thanks.
Right, I think it's really a very good point, which you just mentioned, the transport costs. And although a lot of older people don't tend to be as IT literate, those that have actually got access to FaceTime, an iPad, a computer with a camera, and often I found today, I was doing this with one older lady who lives with a daughter. The daughter was very IT literate, so she was able to be the facilitator, and I was able to watch her do her sit to stands in front of me on the screen, and she was proudly saying how she felt a lot stronger and was actually able to do more. And it's that simple one. I simply challenged them when they're in my room, how many sit to stands can you do with me? And I do them with them. All right, let's get to 5. Let's see if we can get to 10 today. Because it's just as important as, you know, I'm taking their blood pressure, but actually their sit to stands and their walking is far more important. And so I change the conversation and help them think about what they need to be doing. And it's really quite an engaging way that people seem to give me that feedback that they're actually, you know, interested in doing it because I'm interested in it. So our attitudes as doctors, as clinicians, as nurses, of all different disciplines that are online tonight, our attitudes are really key here. And especially when we know that what Sue mentioned, that it's never too late to build muscle. And no drug will actually improve you more than exercise. And when a lot of older people hear that, they go, you really mean that? I said, yep, you can do it. And I challenge them to actually think about that. So our big challenge for us all is actually we've got to think about this as a long-term condition, a chronic condition, because it's progressive. You have all these episodic deteriorations, highly prevalent, and it has a whole heap of preventable components. So if we're actually really thinking about making a difference, and we think about prioritising our time, which I think Taylor's group talked about, well, we've got to think about why are we doing the work we do? What's our purpose? And I loved Anthony in our group. You know, every patient gets a comprehensive assessment. Every patient, everyone is treated the same. We can actually do it. So that's a really interesting sort of outlook. So Jane, what about, you know, this is thinking about a new way of looking at older people?
Yes, I guess in the past, people, you know, turned up to hospital after an episode where if we can proactively look in our patient populations and actually work out who we can call in for care plans and do health assessments, if we are looking proactively towards this group of patients, we can then start allocating different resources and people within the community. They could be going to the physios, the exercise physiologists, the dietitians, and getting them working at home, going to the exercise classes.
So for many of us already, you know, we think about diabetes and heart disease in exactly this sort paradigm. We have been, trained. We've improved our systems in our practices to start thinking about early intervention. We've got to think about moving from reactive care, that's the care on the left, to the care on the right, which is actually proactive. And actually standing back. If you remember that slide earlier on about what will happen, what's the trajectory? We all are clinicians that understand stuff in the room today. We know that trajectory. If we start thinking about care on the right-hand side, then that can make a difference. I also think a conversation, and this comes from the Robert Hartford Foundation, which has been running this fantastic program around the world about age-friendly health systems. So there are some very basic things, and we think about, we're all time poor, but let's have a little mnemonic, and our friends, the M&Ms here, help this. So I want you to think about these 5 M's. What matters to the person is the number one thing, and you need to put this in your care plan, your health assessment. You need to think about this in any time you're engaging an older person. What matters to them? What's their priority? It might be walking the dog. And what's the dog's name? Do you actually know the dog's name? A simple little thing like that is an engagement piece. It gets you a little further when we think about resistance and motivation. That's what matters to them. Then the way we approach this needs to be in that direction. Mobility is what matters, because every older person knows that their mobility is linked to their independence and their future dependence. So anything they can do to actually keep them mobile and steady, not a falls risk, because that's the language, the way we use our language, frailty, falls risk. People don't want to be labelled like that. They want to actually enjoy their life. And our role as health professionals is to help them along this way. They worry about their medicines and having too many, so they're really keen to actually have a good discussion. Do I need to be on all these things? Why am I on them? Their mentation, depression, dementia, delirium. How many people per day I see that are worried about dementia? We need to sit down, have frank conversations, make sure that we do the good screening stuff. People want to have a conversation. This is not to be avoided. And timely diagnosis of dementia makes a huge difference for people having this conversation. So many older people are depressed, but not recognised. It may be trauma, grief, loss. Sometimes simply discussing this and giving them options rather than antidepressants makes a difference. Malnutrition in Australia is an under-recognised issue, a huge M we need to take ownership of, because as we've talked with Sam in the polls earlier, so many things impact people's nutrition. Their teeth, their lack of teeth, their dementia, their isolation, so many. So we need to think about this. And the frail scale we've introduced you to tonight. Many of you are already doing so, but by getting you to do it regularly, consistently for every person, it's almost like universal precautions. Linda in our group said one of the big issues is actually recognising frailty in the non-obvious. So if we think about, and this is why embedding it in our care plans, every older person over 75, every person that has a chronic condition, we put the frail scale in there. We put it into our health assessments. Then we are more likely to have a conversation. Jane, tell us a bit about this.
Oh, this is a slide I have on my desk when I'm seeing patients and doing a care plan. So I ask them, what part of the body do you think this is? And quite often the patient will say, oh, is it the brain? I have to say, no, this is a cross-section of your thigh. This is when you're 25 on the left and when you're 75 on the right. That's the bone in the middle and the skin on the outside. But that grey mass is your muscles. And this is what is happening to our muscles as we age. And this picture actually gets them looking and thinking, and they can sort of visualise their muscles then, and it engages them. And so we can start talking to them about how these are the muscles of independence. If anything's going to keep you independent as you get older, it will be your muscles, those muscles, the thigh muscles, getting you on and off the toilet, ability to walk. These are very important. And patients want to remain independent. So we can then start talking about exercise programs, protein in the diet. I can show them a few exercises within the room, but quite often as a nurse, I need to sort of engage them to actually start thinking oh, perhaps, you know, they need to see the exercise physiologist or the physio to actually help with these exercises. And it's a starting point. And that's why I always think care planning is not a one-off situation. It's an ongoing. We've got to have relationships with these patients and be seeing them every 3 to 6 months, so that we can sort of build on what we did last time.
Yeah, so great. And I think that's that conversation, the muscles of independence, I've found something that you taught me is a way in, like nothing else, when you get them to actually imagine what they were like 2 years ago, what they're going to be like in the next 2 years if their decline continues. And just getting them to imagine that and visualize it and have this sort of picture starts getting them thinking and wanting to do something. And even if it is 10 sit-to-stands per day at home, that's a progress. So how do you use some of these brochures?
Yes, well, especially the sit-to-stand, I like to give them a brochure to take home so that they sort of remember what we talked about when doing a care plan. I use the Live Well brochures to show them what protein looks like in their diet. Resistance exercise. In my healthy aging clinic, we had folders. So we'd put the care plan in the folder and we'd start putting some brochures just to keep the conversation going and ask them to bring the folder back to each care plan review so that it was an ongoing process.
Yeah, and it's this sort of information, especially it helps them think back to it. And especially if we are doing a phone or a video consult later, we can refer back to that information that is there. It's something family members can also take to actually help them raise their awareness. So let's have a think about the end points tonight. So we've talked about the frail scale. We've talked about how to recognise that, you know, if you score more than 3, people are frail, they're going to benefit. And one of the things that's really important from some of the frailty intervention study is the number needed to treat to move people out of that frail zone is around about 6.8 people. And yes, it might take around about sort of 12 weeks to a year to make progress, but the number needed to treat for blood pressure, for hypertension is about 24. So when you think about the effort that you need to go to, you are going to make a difference. And if you get up in the morning and want to make a difference, that's your purpose, and the number needed to treat for frailty is small, you can make a huge difference to people's overall quality of life. So this is something we've put together for North Sydney. It's a frailty management decision tool. So it helps you think about what the referral options are. So for the FRAI, so L, so what the gaps are. So if people are fatigued, you've got, like, let's use the Epworth scale, let's use a K10 geriatric depression score. Let's look at the reversible causes of fatigue. You know, how well is their medical management? What are the referral options? There they are on the screen. If someone can't get up those 10 stairs, right, what do we need to be doing? These are the steps to take. If people struggle to walk that around the block, which is around about 300 metres, we've got plenty of options for them there. And there's also the free telephone-based health coaching, which often gets forgotten. And in this era that we're all living in now with COVID, this is a really good option. People wanted to be doing some stuff at home, so it's they're struggling to get out. So definitely worthwhile. The home medication review is definitely a huge sort of positive for people. And this loss of weight, as James mentioned, so getting people to start understanding their diet. Yes, the dietitian referral is hugely important, but one of the problems is with EPC and Medicare that most of our older people are maxed out with 5 podiatry visits. So there's nothing left for dietetics. So we've got to, you know, take that in hand and say, well, maybe we can give up one of the podiatry sessions for a dietitian. Maybe we can think about the short-term packages of care that you can refer through My Aged Care. If you put frailty and frail scale on a person's referral and refer for a 6-week reablement program, it's a short-term package of care through My Aged Care. A lot of the aged care providers will actually provide that for people. It's one of the things, I'm not sure whether your breakout groups discussed it, but we often find these are the things in the aged care system we don't know about because no one's out there talking about it. And we actually only learned about it through these sessions, didn't we, Sue? That it was actually available. So I've actually made a whole heap of referrals through My Aged Care for 6-week programs that the older person gets involved with. So what summary, all right, recognise frailty is a long-term condition. Rather than just responding, you're just getting old, not much you can do. This tonight, I hope, gives you different conversations to have with your older people. Use the screening tool every interaction you have. Make sure you are weighing your older person at every interaction. It's like a gold standard quality indicator now, older person's care. Watch the weight. Multidisciplinary team care can make that difference. But remember, what matters? It only works if the older person is involved in the goal setting. Dignity in the care of older people is vital. And as Sue has taught me this lovely phrase, you can't turn back the clock, but you can wind it up. So remember this little picture from earlier on? This should be embedded in your memory, thinking about the trajectory of decline. And if you want to make a difference with the people you see, you can intervene much earlier. Sue's talked to us about the clinical practice guidelines. There's strong evidence on if we use a tool to identify physical activity resistance training and the polypharmacy, because as Yog said a bit earlier, Sam, there's so many people that are on medicines with anticholinergic side effects. It slows them down cognitively and physically. It has an impact on their life. Too many opioids keeps them in their couch doing nothing. Deconditioning all the time. So these are really critical areas. Just in case you missed it, there's a frail scale here. So this website that Sydney North has put together gives you these clinical resources, the referral options, and a whole lot of patient information. So if you simply go to the Sydney North website, put in frail, you'll find it. Health Pathways, who's one of our sponsors for tonight. This is really important because the North Sydney Health District and the Primary Health Network in North Sydney have really made a huge effort to actually put together pathways so that it is easy to find the right services for your older people. And they've got a very specific older persons one. It helps us understand this coordination. We get the right referral options instead of trying to go, where do we find something? And it's usually within your local community. This one was launched in 2017, and the overall health pathways, they've got 427 pathways live. Here in Adelaide, I look at that and go, oh, I've only got a small fraction of that. So you're doing fantastically well in North Sydney. So these are the options for older person's health. And I think this is a very, very good sort of way of looking at it. So there's your username and password. So all health professionals online tonight can access Health Pathways to find options for your older patients. And by the way, if you've got older parents, grandparents, aunties, uncles, use it for them. Help them understand it. So I won't do the demo tonight, but there's the Health Pathways, and the gateway is the password for the North area, so just a bit short of time. So you can log into it, you install it on your desktop, there's a little icon that'll pop up, you can have it on your phone as well, and you've got the feedback button. And Dr. Helen Wainwright, great resource. There's her email address if you want to talk to her about anything that's concerning about pathways or something that's not making sense. If you go down a pathway, go, oh, actually that's not where it needs to be, let Helen know, she can help you out. So if you've got any questions and answers for Sue, myself, Yog, or anyone, or Jane, you can pop them into the chat, or if you want to say farewell as well. We understand we've gone a little bit over time tonight, but I really want to thank Sydney North and the whole Frailty Initiative team. There's been a great advisory group behind, and many of you have been facilitators tonight. Your passion and enthusiasm has been fantastic. Sue, your leadership in this area has been fantastic as well, so thank you. But I'd also like to, our Sydney North staff behind the scenes have put this together. Yes, we had a few little tech issues, sorry about that. But they're also looking forward to your evaluation to see whether this has given you the opportunity to reflect on what are the most important things that you've learned, what are you going to be doing differently tomorrow in your practice, whichever discipline you're in, and some feedback on topics for the future and ways we could all improve. So look forward to some questions if you have any. If you want to put your hand up or just send it through on chat, Sue, Jane, myself can take those questions, or Yog as well, because I'm loving this geriatrician to GP service. So I'm going to campaign for it here in Adelaide. So
doesn't look like we have any questions, Chris, but I'd like to thank yourself and Sue and Yog for attending this evening. It's been a great session, and I'm sure that we've learned a lot. I've learned a lot myself. And anybody interested, any of the GPs interested in coming along and being part of the frailty screening program, please send an email through, and I'd be happy to help you through the frail scale. All the resources are on our website. How to join the program is on our website. And I'd also like to thank the advisory group members who were facilitators for this evening.
Right, and I just one last link. I see Peter's put a great question up there, and it relates, Sue, to something you mentioned. Do you want to take that one, or I'm happy to?
Yeah, look, I'm just happy to say sarcopenic obesity, unfortunately, is quite common. So while you won't get points for the weight loss, you will usually see big problems in the other areas if you use frail scale, and certainly hand grip strength and walking speed are huge in terms of saying someone's frail. So yeah, it's often hard to convince people, but you're looking at the underlying muscle function, which is pretty dreadful.
Well, and one of my tests that I use for this group is actually, again, the sit to stand. So just show me how you get out of that chair. Well, putting your hands across your chest, and they look at me and go, really? And I can do that. And then you just watch them struggle. So, okay, I'd like you to do that 5 times, and they can't do it because it comes back to resistance. You know, their 125 kilogram selves, their resistance is even greater to get those muscles of independence to push them off that chair. So they suddenly look at that, go, wow, okay, no one's ever checked that before. So, and often they're tired, they can't walk around the block. So all of a sudden, they're basically going to have their 3 points straight away. So thank you, Peter, for that question, because, it's on the rise, and it really reflects that we can't just use an eyeball view to actually say this person's not frail. We will miss so many people now, that so many people that are coming through at age 70 that are actually obese already. Okay,
I've got a question. Yeah, thanks, Chris. Just a question more for Sue and Yog as well. Sue, I'm a GP in Waitara and also in Hornsby. So hi, and thank you so much for the talk. Just a question, where can I find what geriatric services are available within and just outside Hornsby Hospital? So the reason I'm asking you that question is because I'm aware of certain clinics, but I just want to know, is there somewhere where I can see and find that all?
It's meant to be on our intranet, and we did redo it all last year. I should have a look and see where that is at. We certainly had redone it, but because it keeps changing all the time, it is really hard. I would agree. You are probably best to ring Yog or I and say, I need this. Can you give
can I answer this question, Sue?
Yeah, go for it.
I think now we've got the Health Navigator. So I think the easiest would be for the Health Navigator to help you find the service that you need. I don't know if it was in the earlier slides, but the PHN would have the details for that. So they're like a concierge service that can help you identify where your local services are.
Okay. All right. Yeah. Okay.
Good idea. Probably a lot easier than our intranet, because even getting onto it can be difficult for us from inside.
Yeah, I agree, Sue. It's always quite a frustration. I'm so close physically to the hospital, but yet so far. Does this Health navigator, my impression was that they would point more to community services. So Linda, will they also point to actual clinics and services within hospitals?
I think they did
that's
when one of our outpatient person tried the service, and they actually pointed back to her when she tried it. So I think they are aware of the local hospitals outpatient services as well.
Yeah, Linda, we do in the Health Navigators, they do have a list of a lot of the clinics, a lot of clinics within the hospital. We've got a list of those, but we've also got a search feature on the website for geriatricians as well within the local area. And some of those have got that, whether they work in the hospital or out of the hospital. You can find that on our website. And Health Navigators, yeah, they're not just for community, they can find you hospital services as well.
Okay, all right, thank you.
You're welcome.
All right, well, look, good night from us. I think we'll say farewell, and everyone can, we've kept you a bit over time, but thank you so much, and look forward to catching up again.